Hi, I'm Mary Ann Smith, and today we're going to talk about age-friendly healthcare and systems, focusing on mentation and the topic of depression. Our goals for today are to overview depression, what it is, and how it is important in the 4Ms. Then we'll do a brief review of some of the best screening tools available and also some interventions. I'd like to acknowledge that this program is one in a series of 8 about the 4Ms and is co-sponsored by the Some Center for Gerontological Excellence and Geriatric Workforce Enhancement Program at the University of Iowa Geriatric Education Center. The content is based on the age-friendly initiative of the John A. Hartford Foundation and Institute for Healthcare Improvement. We really hope everyone will visit the link provided here to learn more about the initiative and how you might apply it in your setting. So, mentation, by definition, is preventing, identifying, treating, and managing dementia, depression, and delirium across settings of care. In acute care, we probably pay more attention to delirium, acute confusion. In ambulatory care, there's a greater focus on depression and dementia. And in senior living, we pay attention to all 3 Ds: dementia, depression, and delirium. So, thinking about depression, clinical depression, and I would like to emphasize clinical depression, not just passing mood. Clinical depression changes how we think and feel in a way that can interfere with talking about what matters, engaging in physical and social activities, managing other healthcare conditions, and enjoying friends, family, in activities. In short, depression can rob older people of their quality of life and, importantly, contribute to a downward spiral of disability. So, I said clinical depression, more than a passing mood. Well, what does that mean? Well, clinical depression is a cluster of specific symptoms that persist over time and actually impair function, and among older adults often contributes to dysfunction and disability. And very importantly, clinical depression can increase the risk of self-harm and suicide. One of the biggest issues that we have about depression is that it does exist on a continuum. Nearly everybody has a little depression from time to time. And that leads us to think that it's somehow normal. So we see older adults in late life with depression, and we think about their circumstances, their healthcare condition, the loss of a loved one. And we think things like, well, who wouldn't feel that way? I mean, after all, being sad is understandable. Goodness, you have every right to be depressed. Now, that's kind of a strange way of thinking about it, because we wouldn't say they have a right to have high blood pressure or they have a right to have diabetes, but because it exists on a continuum, we think depression is somehow normal for people to have, and therefore it's unrecognized and untreated among older adults. There are 2 hallmark symptoms of clinical depression: depressed mood, which is the thing we always think about: sadness, discouragement, crying, being down in the dumps, having the blues, but also loss of ability to experience pleasure in nearly all activities that usually have been fun. That's known as anhedonia. And that leads people to withdraw, become inactive, to isolate. They feel like nothing is fun anymore. They just don't care. And that can be very confusing. There are four additional symptoms additional symptoms, 5 total. So they can have both hallmark symptoms or one or other hallmark symptoms. But the point is that they have a total of 5. And as you look at this slide, it's so important to think about how many of these symptoms are actually physical symptoms: weight loss or gain, sleep disturbance, insomnia, or sleeping too much, psychomotor, meaning we're ramped up or we're slowed down, agitation or retardation, fatigue, loss of energy, feelings of worthlessness, inappropriate guilt, difficulty thinking, concentrating, making decisions, and then the last one, recurrent thoughts of death and suicidal ideation. So this idea of anhedonia, the hallmark symptom that causes loss of ability to experience pleasure in things that are usually fun, can be present when sadness isn't. So anhedonia is present and sadness is not. They have a loss of interest, they're apathetic, they're withdrawn, they're indifferent, they have no motivation. And then we add these other symptoms: sleep, appetite, loss of energy, slowed down motor activity, and we assume the person has a physical illness, or they have problems thinking and concentrating, and it looks like dementia. So there are lots of different ways that symptoms combine in a late life depression, that depression is overlooked as the cause. Depression also overlaps with dementia. So just like a delirium can overlap with a dementia, so can depression. So as the slide shows, there's a standalone version of depression, and then there's a depression that overlaps on top of a dementia. And in fact, some people say 30% of people who develop dementia simultaneously become depressed. And in their depression, they look more impaired than they actually truly are. If we treat the depression, much of the cognitive impairment, the loss of ability to function, goes away. So very important for us to distinguish that depression can exist alone, but it can also overlap on top of dementia. So when we think about the course of depression, it's a fairly rapid onset of symptoms, about over a 2-3 week period of time, where the person becomes very depressed, very impaired, and then it persists in the absence of treatment or intervention. And honestly, if the person doesn't kill themselves in a matter of months or up to 2 years, they gradually will return to their baseline function. So they will get over the depression. Many people do on their own. That's not true for all, but for many people that is true. So when we think about depression, it's important for us to reflect on our key actions again. We want to stop and assess the person and then act on our findings. So we want to think about risk factors, presentation of how they look, their presentation, think about their history related to depression. And I would like to emphasize thinking about how some people become depressed, are not treated, and then recover from it. We want to think about episodes in life where they had depression-like symptoms, were not themselves, went to bed, were sick, couldn't figure it out, because it may not have been identified in the older adult population as being depression earlier in life. So we want to think about that. We want to think about symptoms. We want to know if they've ever been treated for depression previously. And certainly we want to screen for current depression symptoms. Then we'll act on our findings by referring for further evaluation, treating symptoms, and supporting function, and also referring to resources to help people maintain their function. When thinking about assessment, again, this is a lot like doing a cognitive assessment. We want to normalize it. I'm going to assess your mood just like we would check your blood pressure or your lungs. And as before, depression screening is part of a Welcome to Medicare and Medicare annual wellness visit. In terms of assessment, there are several really good scales that we'll be talking about. We like the patient health questionnaire, but the depression rating scale, the geriatric depression rating scale, is another really good option. The main point is to quantify symptoms using a standardized measure. And as with other aspects of mentation, use a scale that makes the best sense for your setting and care culture. So let's start with the patient health questionnaire, 9 items, that reflects the 9 diagnostic criteria for a major depressive disorder. So we rate the 9 items on a 4-point scale, which we'll talk about in a minute, and then come to a total score. The PHQ-2 uses the first 2 items, the hallmark symptoms of the PHQ-9, and scores it. And then, as I said before, the PHQ-9, we score by including all 9 items. So let's think about that some more. On a PHQ-2, we rate the 2 hallmark symptoms: little interest or pleasure in doing things, anhedonia, and feeling down, depressed, or hopeless. And we rated on that 4-point scale: not at all, more than half the days, several days, nearly every day. And we give it a score of 0 to 6. And a score of 3 or greater suggests that we go ahead and score the remaining items on the PHQ-9. So here we go. We've already scored little interest and feeling down, so let's go ahead and score trouble falling or staying asleep, feeling tired, poor appetite, feeling bad about yourself, concentrating, moving slowly, being restless, or thoughts that you'd be better off dead or hurting yourself in some way. We score those items just like we did the first 2, 0, not at all, to 3, nearly every day. And then we add the scores for the 9 items, total score of 0 to 27. And then there are some really nice standardized cut points to help guide us about what our next steps probably should be. So 0 to 4, not a problem. Depression isn't significant. 5 to 9, mild depression. Keep an eye on it. Maybe check again later. 10 to 14, 10 or greater, really is considered clinically significant and worthy of treatment. So we want to be thinking about interventions. 15 to 19, that's moderately severe clinical depression and is definitely worthy of treatment and possibly would warrant using a medication intervention. And certainly 20 to 27 is a really severe depression. The depression rating scale, or geriatric depression scale, has been around for a long period of time and is based on the idea that older adults often have physical health problems that are not related to their mood, to their clinical depression. Therefore, we should think about rating things that indicate depression but don't include necessarily physical health problems. So I know this is microprint and it's really hard to see, but the geriatric depression scale is widely available. You can Google it, find it. It's considered public domain. Put it into place, use it in practice, and you can find all of these symptoms and read them more carefully and easily when you find the form yourself. But the idea here is that in scoring 0 to 30, you can have mild or severe depression. In either case, we want to return and use the diagnostic criteria to think about making a diagnosis of clinical depression. The 15-item version of the geriatric depression scale, the short form, is probably a little bit easier to use because of its length, and again, has a scoring scheme that says over 5 is suggestive of depression. 10 is clearly indicates a depression, but any score over 5 should be worked up further. So after we quantify the symptoms, and I think it's just so incredibly important to quantify the symptoms, know how many, how often, and really think about that carefully. I will say we would never think about letting a person who has all the risk factors for high blood pressure go without taking their blood pressure and quantifying it and monitoring it on an ongoing basis. It's unthinkable just because they have a lot of symptoms that look like they might have high blood pressure. The same thing is true for depression. Because the person acts depressed, looks depressed, sounds depressed, and maybe has had a series of events that would justify their being depressed, doesn't mean that we shouldn't quantify the symptoms and then act on those symptoms, treat the underlying disorder. So taking action is guided by the severity of the symptoms. Think about it. Is it mild, moderate, more severe? We want to think about the risk of self-harm. And we clearly want to think about the older adults' treatment preferences. There is a good body of literature that says older adults don't necessarily want more pills. It's contrary to what a lot of providers believe, that everybody wants a pill to fix something. But older adults, in particular, related to mind pills, are not excited about that option. So talk about it. Think about it. Think about what matters most to the person, and then go from there. We also want to think about the interactions among the 4 M's. Difficulty identifying what matters, meaning we're trying to have the conversation. Tell me about your goals. Tell me about what you would like to be doing if you felt better. And the person is so kind of listless and slowed down and not able to even tell you what is fun because they've got that loss of ability to experience pleasure. So nothing matters. It's going to be maybe hard to have the conversation. So keep that in consideration. And the idea is just persist. Keep talking. Keep trying. We also want to think about medications that can directly cause depression. And there's a list of them. We'll talk more about that in the module about medication. Is a person's mobility challenged because of their fatigue, their lack of energy, their loss of motivation? They can't get themselves up and get going. And as they don't get going, they lose capacity and downward they spiral. And the other question is their depression masked by dementia? Are we thinking that the problem is really that they've got a cognitive impairment, and in the process, we're missing the fact that there are depressive symptoms there that are highly treatable? And of course, the other question is, could it be all of the above? And in many situations, it is. So let's address problems that cause and contribute to depression. Think about it carefully. Medication, health-related problems, age-related losses and changes, and may I say, stroke, diabetes, heart disease, and chronic pain interact with depression in a really interesting way. Stroke tends to make depression worse, and depression tends to make it harder for the person who's had a stroke to manage their symptoms. Same with chronic pain. We never want to treat pain until we first treated their depression, because pain truly turns up the volume on depression, and depression turns up the volume on pain. So there are these really important interactions for us to think about. And certainly we want to think about the age-related losses, retirement, bereavement, relocation, unexpected, unwanted, and that circles us right back to what are the resources and supports that may be needed to help the person not just manage the depressive symptoms, but the antecedent conditions, the things that cause and contribute to persisting depression. There are really two main treatment approaches: behavioral non-drug therapies, listed here on this slide. I'm going to talk about them in just a minute, and antidepressant medications. And as I said before, for mild to moderate depression, lots of older adults prefer behavioral therapy as opposed to medication. So very important for us to explore options with the older person as we think about what matters most to them in the context of their having depression. So behavioral activation, I think, is so very, very important. A good body of literature supports the fact that scheduling pleasant activities, almost like we schedule doctor's appointments or take our pills on a daily basis, can help reduce depressive symptoms. That helps us establish healthy routines and have positive experiences, and leads to both better mood and better function. The point is, keep it simple, failure-free. So think about what are pleasant activities that the person might like to try doing again, and schedule it. There's a lot more about this, but this is just kind of a brief overview. We also know that physical activity, physical exercise, reduces depression. Engaging in physical activity 20 minutes a day, 5 days a week, can decrease depression and improve our health, both. We'll talk a little bit more about that with mobility. The idea here is that physical activity really helps break the cycle of the less I do, the worse I feel. And the worse I feel, the less I do. And around and down the spiral the person goes. So physical activity and exercise is really important and often overlaps with behavioral activation. We know that counseling and talking therapy is also very, very helpful for older adults, and often the first line of treatment. Older adults don't necessarily want more pills, and they certainly don't want more mind pills. So we may need to explain goals of therapy and talk about problem-solving therapy or solution-focused therapy. Remind them in today's world there are no couches, no talking about dreams or mother, unless she's a current problem, and that is a possibility, I guess. And most of the approaches are problem-focused, and they're very brief, limited number of visits, and focus on finding solutions to current challenges. So moving on, thinking about antidepressant medications, here we want to apply age-friendly practices for medication use, which means use a medication that has the lowest side effect profile. We want to avoid medications that put older adults at higher risk. Tricyclic antidepressants or MAO inhibitors. Those are older categories of medications that are still used, but we've got lots of really good new antidepressant medications that are just as effective. We want to monitor side effects or possible adverse effects, and the prescribing protocol is for any kind of psychotropic medication with an older person is start low, go slow, but keep going until the symptoms resolve. And by that, we want to assure that we go slow, titrate it up, but we want to monitor outcomes using that standardized scale to assure that the person is recovering fully from the clinical depression. And we also want to educate the person in advance about the importance of taking the medication, of adherence. So adherence is so critically important with antidepressant medications. We need to educate the older person and their family support or caregiver that these are not drugs that work immediately. And these are not drugs that are addicting. They don't make you high. You do need to take them every day. And it can take up to 12 weeks to get the full benefits. There are side effects that may occur, and that should be part of the conversation, and which side effects should be reported and which side effects are transient and often go away. We want to talk about antidepressant medication as another illness treatment, just like we treat diabetes or heart disease or other health conditions. It's just another illness treatment. So work to normalize it. So in summary, clinical depression is often masked and misunderstood, meaning that we need to think carefully about how the person presents and then apply screening tools and other scales to quantify the severity of symptoms, how many, how often, how long, and really think about the impact of depression on the person's function. We want to address causal and contributing factors. So circling back and thinking about, has a person had recent heart condition? Have they had a stroke? Are they having pain? How do those things interact with depression and make both depression and the health condition more difficult to treat? We certainly want to assess interactions between all of the 4 M's. What matters most? Is depression making it hard for the person to articulate what is really important to them? What do they really care about? What would they like to be doing? Is medication actually causing more depression? Is it triggering changes in mood? Is the depression affecting their mobility, making it more difficult for them to get up, get going, and do the things that matter? And certainly we want to think about the interaction between mentation, depression, and its overlap with dementia. So thinking about that, we want to then move ahead and treat the person according to their preferences. Not all people want more pills. Talk about the options. Is a behavioral intervention like activation or activity or talking therapy a good starting point and then go to medication, or should we start with medication now? But it all depends on what the person prefers and how we can best support them to do what matters most. Thank you.